The PREOPANC study was initiated about 7 years ago in the Netherlands, and to do so, it was very difficult to convince at least the surgeons that probably you could also operate on pancreatic cancer patients after pre-operative chemoradiotherapy. So that was actually the main problem of starting this trial. And also because we thought it could be difficult to include patients, because until that time it was normal to directly operate on patients with proven pancreatic cancer. So the initiation of the trial was rather difficult, but after an inclusion period of about 1 year and a half, the inclusion was actually through the scheme, and it was actually concluded and closed. So we now have a follow-up of around nearly 5 years. And what we saw is that actually the initial results with not all the events that we needed for closing the trial, that it was not significant, the survival time, but now with a much longer follow-up, there is a clear survival benefit for the patients who actually receive neoadjuvant chemotherapy. And that included patients with resectable and borderline resectable pancreatic cancer. So the randomization scheme was actually that patients were either directly operated and received 6 cycles of gemcitabine, because when we initiated the trial, then gemcitabine, at least in the Netherlands, was still the standard of care. There was not at that moment the publications about FOLFIRINOX yet, so therefore the standard arm was gemcitabine. And in the other arm, so the treatment arm, we started with gemcitabine, then we had gemcitabine in combination with radiotherapy, gemcitabine cycle 1 again. Then we had the surgery, and then the patient received 4 cycles of gemcitabine. So the total of the gemcitabine cycles was equal in both arms, but in arm A, actually the patients were directly operated, and in the other arm, they received upfront surgery. And all the patients should actually have suspected pancreatic cancer due to the fact that we did cytology or histological biopsies with endoscopic ultrasound prior to the inclusion in the trial. So that was actually the trial treatment, the trial design, and it was a nationwide multicenter trial in the Netherlands. 16 centers were included, and the total of included patients was 246. So the primary endpoint was overall survival by intention to treat, which is actually very important to figure that, to point to that, because intention to treat is not always presented in all the adjuvant trials, because a lot of trials do select first the patients to give them adjuvant when they are good enough to receive adjuvant therapy. But the aim of our trial actually was that we needed the intention to treat analysis for the primary endpoint. And the secondary endpoint, of course, were things like resection rate or zero resection rate, and of course toxicity. So the mean age of our patients was around 66 in both groups, and also the distribution between mean and female was equal and nearly 50%. So we looked at, first of all, the resectability of all the patients, so that was by intention to treat, and that didn't differ between the two groups, but was rather disappointing because it was around 50%. But that's actually what is in real life happening with patients who present with pancreatic cancer. And also the borderline resectable patients were equally distributed between both groups. Going to the results, then we saw that in the neoadjuvant group, around 70% of all the patients received a resection, and that was 95 in the upfront surgery group, so the patients who didn't receive any treatment. Then the total of all the patients who had an R0 resection, that only considers the patients who by definitive pathology actually did have pancreatic cancer, because in some of the patients, in around 10% of all the patients in the whole group, the diagnosis was changed from pancreatic cancer to distal bile duct cancer or any other form of cancer, but they were still adenocarcinoma. So that's also a problem by diagnosing pancreatic cancer, that sometimes you end up with distal bile duct cancer, and those patients, they actually in that trial didn't receive adjuvant chemotherapy. So all the further analysis are done only on the patients who actually did have pancreatic cancer, and that means that the R0 resection rate was significantly higher in the neoadjuvant group. That was around 72%, which in the upfront surgery was 43%. And also what was interesting to see is that the N0, so that means no lymph node metastasis, was much, much higher in the group of patients who received actually the neoadjuvant. That was around 65% compared to the 18% of the patients who received the upfront surgery. And then coming to the main result is that the overall survival by intention to treat, we had a median overall survival in the upfront surgery group of 14 months compared to 15.7 in the neoadjuvant chemoradiotherapy group. And importantly, the 5-year results did show that the upfront surgery, only 6.5% of all the patients included were actually still alive, which was 20.5% in the neoadjuvant group, and that's really significantly. What also important to tell is that we also did sub-analysis, for instance, of all the patients that indeed underwent a resection, and also in that group, the median survival and the 5-year survival was very significantly better than for all the patients who actually received the chemoradiotherapy. And that also counted for the patients who started actually the adjuvant therapy. Also in that group, we saw that the upfront surgery did far worse than the patients who received upfront chemoradiotherapy. To conclude is that we think that at least this trial showed that neoadjuvant therapy, first of all, was feasible, and that our regimen was better than upfront surgery. So that means that at least chemoradiotherapy with gemcitabine and radiotherapy is better in patients with borderline and resectable pancreatic cancer compared to upfront surgery. So that opens the way, of course, for other trials. And we just closed the PREOPANC 2, which actually compared the new arm, so that means the chemoradiotherapy with the upfront FOLFIRINOX in patients also with resectable and borderline resectable pancreatic cancer. I think it's also very important to say that this first worldwide trial, randomized trial comparing upfront surgery versus neoadjuvant chemotherapy in pancreatic cancer, opens the way, at least in the Netherlands, to include much easier in patients in randomized trials studying neoadjuvant therapy. That's very important to say, that at least this trial opens the path for new clinical trials. On behalf of all the authors, I want to thank all the people who actually participated in this trial, and this was done and executed by the Dutch Pancreatic Cancer Group. So we are very proud that we have finished this trial, and we look forward to the results already of the new trials, which of course the PREOPANC 2 has already finished. Now we start up the PREOPANC 3, 4, and 5. So yeah, we look forward, and we hope to make little steps in the treatment of patients with pancreatic cancer.